Hi everyone, my name is Raylan Johnson, and today I'm going to be presenting my project over Texas Vision for Elders Initiative, also known as TBE. It is going to be my pilot program implementation and evaluation report. On this slide, you're going to find my YouTube link. On my first slide, you're going to see my key health issues. The key health issues, diabetic retinopathy, is a leading cause of preventable blindness among elders with diabetes in Texas. Delayed screenings, low awareness, limited access to specialty eye care, and transportation barriers are what cause this health issue in amongst 65 and up elders. For my rational, seniors often wait until symptoms appear rather than making the appointment to be seen for the year and to be able to get that dilated eye exam, making vision loss irreversible. The next rational is early detection through annual dilated eye exam prevents progression of the diabetic retinopathy in the eye. For our program mission, we are doing this program to help prevent loss of vision among seniors with diabetes by increasing awareness, facilitated screenings, and reducing access-related barriers. On my next slide, we're going to go over the description of target population in the project setting. For the population, we are looking for adults aged 65 and up diagnosed with diabetes, either type 1 or type 2, individuals with low awareness of diabetic eye exams, and also residents accessing local community clinic services. For the setting, we are going to be located in Plano, Texas at Constant Eye Care Clinic. It is a very safe and familiar, trusted environment that has been there for 12 years now. It is provided in-kind space and clinical support. For my next slide, we're going to be going over the objectives and the goals. For my program objectives, the first one we have is increased knowledge of diabetic retinopathy among older adults with diabetes so they understand risk prevention and the importance of an annual eye exam. My second objective is going to be improving immediate access of screenings and appointment scheduling by offering services directly in a trusted clinic setting. My third objective is going to be increasing follow through with preventive care, especially scheduling and completing dilated eye exams to prevent avoidable vision loss. On my picture on the screen right here, you're going to see what a normal retina looks like. This is a healthy picture of the back of the eye called an OCT wellness screening. The one below it, you're going to see all these little white spots that are in the back around the retina. The circle spot right here is going to be your retina, and this little dark spot right there is your macula, which is your 20/20 spot. The little white spots that are on the outside border is going to be diabetic bleeds. With those diabetic bleeds, it does cause people to lose vision. You can lose it from your peripheral or your central vision with having diabetic retinopathy. For our program goals, we want to at least recruit 25 eligible seniors with diabetes. We want to at least achieve 90% of seeing that they have some diabetic retinopathy risk. And then we want to provide at least 100% visual acuity screenings while we're doing this inflammation. We also want to ensure at least 40% schedule a dilated eye exam after learning about this inflammation. Now on to my next slide. This slide, we're going to be going over my project inflammations and strategies. So for my inflammation, it's going to come in within 3 stages, which will be executed during one 90-minute event. For the first step of the inflammation, we're going to just have our education strategy. Basically, we're going to have a 60-minute seminar over protect your sight from diabetes. During this seminar, people are going to be handed out educational pamphlets in regards to how to cover your risk, how to prevent having diabetic bleeds in the back of the eye that causes you to lose vision. This will also be led by a bilingual educator because diabetic retinopathy is found mainly in Hispanic cultures. It is also found in other cultures, but Hispanic cultures do have the higher chances of having diabetic retinopathy because they don't go in for their annual dilated eye exams. For our second communication strategy, we're going to have still the bilingual educator, but we're also going to have a one-page bilingual handout so the people that are Spanish speaking will be able to understand what the handout is stating in regards to their medical issues. We also want to reinforce learning and serve a cue to action, meaning that when we're going over the steps, we want to just have specific points that we get across to everybody so everybody understands the seriousness of the situation of having diabetic retinopathy. For our last step, which is behavior number 3, we're going to do behavioral changes support strategy, which is an on-site visual acuity screening. Basically, what a visual acuity screening is, we'll have the patient stand at least 20 feet from the visual screening. We're going to test both eyes open, and then we'll test one eye, right eye, and then one eye, left eye, just to see what their visual acuity is. During this time, we'll also be assisting by scheduling dilated eye exams immediately if we do see signs of diabetic retinopathy. This also is going to help reduce any type of access barriers, so we can go ahead and get those people assisted in getting in for a dilated eye exam. For our marketing, we did go ahead and put a flyer up of what our flyer is going to look like, which was going to be handed out in mainly libraries, senior citizens' homes, and in other clinics like other doctors' offices that are mainly their PCPs. On this flyer, you're going to find the date and time of when the implementation and the training is going to be held and how long it is going to take. You will also see the location where it's at and the phone number of the clinic. It also will state who should be attending and what the objective should be for you to be able to attend, which is living with diabetes and adults 65 or older. It also asks you what to bring, which is basically just yourself, so you can do a visual acuity check, and then what you will learn during the seminar. On my next slide, I'm going to be going over our project partners and collaborators. For my project partners, I did go ahead and choose Constant Eye Care Clinic. At this clinic, they do have a big enough venue to withhold the 25 people at one time. They also have screening tests where we can do the visual acuity and also do the OCT screening if needed. They also have a program coordinator and a community health worker that will come in and help people get arranged with transportation, how to get there, how to get back home. We will also have a bilingual educator that will be working as a technician and also scribing for the doctor. These are two pictures within Constant Eye Care of people that have had a diabetic eye exam done and who are over the age of 65 or right at the age of 65. On my next slide, we're going to be going over the logical model showcase and discussion. I put it into 3 categories: our inputs, activities, and outcomes. So our inputs are going to be our staff and clinic space. Activities, we're going to have an education and handout activity for all the participants to fill out and to learn about. Our outcome is to increase knowledge of diabetic retinopathy. For screening tools, we do have on-site screening tools, which will be the visual acuity and also the OCT screening. After they do those 2 or 3 things, we'll do immediate scheduling if we do see signs of needing a diabetic eye exam. We will then have printed materials. With the printed materials, you'll have appointment support to show you what's going to be going on in the appointment. It will also have insurance listed to let them know if we do take insurance. A lot of people that are 65 and up are on Medicare. With that printed out materials, it is a greater follow through and reduces vision loss just because they are going to have something to leave with. This gives them at least a handout to take home to keep on reading and to remind them, hey, I do need to go get a dilated eye exam because I could possibly have diabetic retinopathy. For my project needs, we're going to do our staffing needs, and then on the other side, I have my budgeting needs. For the staffing needs for the role, I will need a program coordinator, which will take about 25% of the job. The purpose of that role is to oversee the planning and logistics and the partnerships to be able to implement this project. We also will need a bilingual educator. Due to Texas being one of the largest states that have the most Spanish speakers, I feel like a bilingual educator will be good to be able to speak to all kinds of people that we have that walks in. They will also help lead the educational session. So if anybody does have questions that are understanding it, they will be able to answer it in English or Spanish. We will also have a community health worker and they will assist in registration and following up with the patients. With the registration, that will basically meaning helping them scheduling the appointments and then also making sure that they're following up with each and every single one of the 25 candidates that we do have come in to make sure if they are showing signs of diabetic retinopathy that they come in to have that follow up for a dilated eye exam. We will also have a contracted optometrist, which will provide the screenings and support the scheduling. For the screenings, the optometrist will also check the visual acuity to see if glasses could help, or she'll see if it is actually just diabetic retinopathy, the reason why that they are not seeing as great. For my budget, I do have a total cost of $4,265. Basically, this will cover personal stipends, printing out materials, screening/exam supplies, and refreshments for the participants. On my next slide, we're going to go over how the strategies were implemented. How the strategies were implemented was by education strategy, which was delivered a 60-minute session of Protect Your Eyes from Diabetes. Also, that reviewed risk factors, prevention, and need for annual eye exams. The next one is the communication strategy, which was distributed with a one-page bilingual handout to every candidate. It also reinforced key messages and provided action steps for each candidate that wanted to take the action to make sure if they had diabetic retinopathy or not. And then the last one that we have for our implemented strategies were behavioral changes strategy, which is completed visual screenings on site, scheduled dilated eye exams immediately after sessions if needed one. For evaluation procedures, we did a attendance sign-in guest sheet. So once the 25 candidates did come in, we did just have them write down their first last name and then also their date of birth, just so we can make sure that they do hit that 65 or older. We also did provide a post-educational survey / a knowledge check after we did do the 60-minute inflammation strategy. We also did a clinical screening login. So every visual acuity, we will also log every single person's acuity. So if they do come back for their exam, we can see if maybe their acuity has gotten worse or has gotten better to see if we can decipher if it is diabetic retinopathy or if it's something else that could be going on like cataracts. We also have appointment scheduling lists. So whoever does schedule, we will have a list stating that they did schedule an appointment, and then it will show how many of the 25 people did schedule to come back for a follow-up. On my next slide, it's going to be going over our evaluation findings. For my evaluation findings, you'll see my two graphs here that I have on the screen. The first one is going to be goal versus actual results. You can see at the bottom we have percentage/count, which goes up to 20, 40, 60, 80, 100. And then we have at the bottom, we have attendance, screen, knowledge, and scheduled of exams. You will see that the orange is actually supposed to be green. That's the actual goal itself. And then the actual people that did it will be the blue, which is on all of them more than what we set as for our goal. For the people that actually scheduled the eye exam, we had more people not scheduled compared to the people that did schedule, just due to a lot of people already had a little bit of knowledge of what diabetic retinopathy was from their PCPs telling them that they need to go get a routine eye exam done, a dilated one, just to make sure there were no diabetic bleeds in the back of the eye. On my next slide is going to be our evaluation of implications, our key takeaways based on the findings. We have another chart here for knowledge gain, same-day screenings, and then scheduling of exams. For on the side, you'll see our percentage still going up 20 to 100. For knowledge gain, we had 93%. For same-day screening, we had 100%. For scheduling of exams, we had 46%. The key takeaways were seniors responded positively when education immediately led to services access. So basically, when we had the patients come in, once we went ahead and told them about what diabetic retinopathy was, and we handed them the handout and did the seminar, then it led them to immediately wanting to schedule the appointment or wanting to do a follow-up or wanting to do a diabetic eye exam or a dilated eye exam to make sure that they didn't have any diabetic bleeds going on in the back of the eye that could prevent them to lose their vision. Another key takeaway is same-day scheduling significantly reduced follow-through barriers. So basically, with the same-day scheduling, it helped the people that didn't really have great transportation because we could see them right then and there. They didn't have to worry about coming back the next day and finding a ride for the appointment. They could just go ahead and be seen right then and there with the optometrist that was in office. The last one is knowledge increase, which influences confidence and intent to seek care. So, also with the handout, with the people that didn't really have that much knowledge about diabetic retinopathy, it really increased their knowledge of, hey, I really should get diabetic eye exams done and a dilated eye exam done to make sure that I don't have any diabetic bleeds going on in the back of the eye. Because if I don't get this treated now, then I won't be able to see it again because it is an irreversible disease that goes on into the back of the eye if it is not controlled. On this next slide, we're going to go over our program fit discussion. I put it in three categories. One is feasible, appropriate, and acceptable. For our feasible, we have a single event model works within clinic workflow. The next one is does not require major policy or staffing changes. Basically, whoever's there on the staff can be able to implement the implementations and they can just do a regular day. And if people want to schedule, they can go ahead and put them in on the books. Required supplies already exist. Required supplies already exist within the clinic setting, meaning that we already have a visual acuity on the wall. We already have an OCT wellness screening, and if possible, if they need a visual field, they'll have that also in office. And then can be repeated monthly or quarterly with minimal costs. So, majority of the people that are 65 and up are on Medicare. Medicare normally does cover one exam per year, but if it is a diabetic eye exam, some plans do give them an eye exam every 6 months just to make sure there is no progression of the diabetic retinopathy in the back of the eye. For appropriate, we have addresses a known gap in annual diabetic eye exams. We also have matches needs of older adults who often delay care. And then we have aligns with clinic priorities and community health goals. And lastly, we'll have provides education in an easy to understand format. So it is appropriate setting for people to come into an optometrist clinic. Um, that's basically what our job is to make sure there are no early on diseases or diabetic bleeds in the back of the eye once they do come in. A lot of people think that they have to go specifically to an ophthalmologist. You can go to an ophthalmologist, but your optometrist can also see you for diabetic eye exams or dilated eye exams or any type of medical eye exams as well. In our last column, we're going to be going over acceptability. We have high attendance and participants indicating readiness. And then we have seniors express trust when services were delivered on site. And then staff reported smooth flow and manageable workflow. And then participants showed willingness to schedule a follow-up care. This is all in regards to being actually in the clinic base. We can show everybody the actual testing that we have and the procedures of how a diabetic eye exam goes and how it is to be dilated. This just gives people over the age of 65 the reassurance that, hey, it's okay that you have to do this exam. Nothing is going to be out of the ordinary or be long and drawn out. It's these few little steps we have to do just to make sure there is no diabetic retinopathy in the back of the eye. On my next slide, we're going to be going over program modifications. For the program modifications, we have our recruitment, our access support, our follow-up, and our participant engagement. For our recruitment, we'll add referral partners, more senior citizen centers coming in, more PCP offices, maybe also giving them out to churches. We also want to use reminders as calls and texts before the event happens 1 to 2 days prior. For access support, we want to be able to provide transportation assistance or a ride coordination in regards to people that can't be seen same day and need to be scheduled in later on that week or the following day. We also want to pre-reserve exam slots immediately following education sessions. So if we know we're going to be in the clinic that day, we want to at least have opening slots on the schedule for if people want to be seen that same day for a diabetic eye exam, they can go ahead and be seen that day. For a follow-up, we want to add check-in calls every 4, 8, and 12 weeks. This is basically just giving back to the um, patient to make sure that they understand what our findings were. If they do need to go and be referred to someone else, like a retinopathy doctor or a retina doctor, then they can go ahead and do that. Or if they feel more comfortable coming in back to us to be able to do those screenings, we can do that as well. We also want to track attendance at scheduled exams and troubleshoot barriers. The next one we have is participation engagement. We want to offer small incentives like Once people do come in, we want to have maybe little goodie bags as either lens wipes or a cleaning cloth or a cleaning spray for their glasses, maybe even mints, something that just shows back to them like a small little offer of like, oh, thanks for showing up and thanks for coming to this seminar for learning about diabetic retinopathy. We also want to invite caregivers when it's possible to support follow through. So basically, we want to be able to invite whoever the caregiver is for that individual, for that elder, if they do have a caregiver, just so they can come in and understand what steps that they need to take in regards to slowing down the progression if they do have diabetic retinopathy, and then also stating what the next steps are for the care plan. For my concluding remarks, the TVE pilot successfully demonstrated that combining education with immediate access to screening and scheduling can move older adults with diabetes from awareness to into preventive action. Participants showed strong engagement, improving understanding of diabetic retinopathy risk, and meaningful flow through with eye care appointments. The clinic-based delivery model proved feasible, appropriate for the target population, and well integrated into existing workflows. The results provided a clear foundation for scaling the program, expanding recruitment, and strengthening follow up touch points. With minor modifications such as enhancing reminders, transportation support, and extending tracking, the full program has strong potential to reduce preventable vision loss among seniors. Ultimately, this pilot confirmed that early detection, education, and access support are crucial components for improving eye health outcomes in at risk older adults. For our ending questions, I do have 3 questions. The first one is, which components of the pilot do you believe should be scaled first to achieve the greatest impact? The second one is, which of the 3 strategies, education, communication, access support, had the strongest effect on participant flow through and why? And the third question is, what challenges or barriers should we anticipate when expanding this program to additional clinics or committee settings? On this slide, you're going to find my references that go along with this presentation. I just want to say thank you for your time and your attention. At this point, I would like to open the floor for any questions, comments, or concerns regarding the pilot program findings or next steps. Please feel free to share your thoughts. Your feedbacks will help me strengthen the full implementation of this product. And on this slide, you're going to find my contact information. I did go ahead and list 2 different emails in case one email doesn't send through right or I don't receive the email through one of them. You can use either one. I just want to thank everybody again for watching my presentation.